I think it's risky because the transducer is going to be distal, and we know. Luckily, there's some nice papers out there which tell you that really, unless there's a very severe stenosis, the FFR is often negative. So, and indeed, most of the recent studies, I think, have indicated that maybe we should just concentrate on flow, and if flow is good in the branch, then that's all we need.
So Bruno, you want to place a wire in the distal LED,
yes,
and you will place a wire in the diagonal.
Yes, because it's a large diagonal branch. There is no disease, but it's a large diagonal branch supplying a large territory, so I think it's safer.
Not just a question, when you look at this lesion on the LED, so we know that the diagonal does not need a revascularization, but when you look at this lesion of the LED, do you plan to place a stent after balloon predilatation, a stent at the ostium, covering the ostium of the diagonal, or did you place the stent just starting after the origin of the diagonal? It's quite difficult to say.
I think if we really had a strategy from the beginning to have covered the diagonal, there would be little logic in having done the FFR.
Yeah.
Because once we had covered the diagonal, it would change. There would still be a possibility, of course, that we're going to change the diagonal. Let's be honest about it. But if it looks angiographically identical after we've placed a stent, hopefully distal, just distal to the diagonal, then we now know the diagonal is not ischemic.
Yeah.
So I think that's what we think.
So you place the stent just distal to the origin of the diagonal.
I think that's what Bruno will try and do. Yeah. It will not be that easy, but I think that's the aim.
The two wire are in place, and now we will do the predilatation. I select a 2.5 by 20 millimeter balloon, and I think that, as Martin said, the most important will be to precisely put the stent just at the level of or just after the bifurcation with the diagonal. So, in fact, after doing the predilatation, we have to evaluate precisely the bifurcation anatomy, and it requires at least 2 orthogonal views. So we will work in 2 orthogonal views to be sure that the stent will be at the correct place.
Okay. This is 20 millimeter length.
20 millimeter length. So
I guess it would be nice for the balloon also to stay away from that origin, because we can place this stent.
Yeah.
Okay, test.
Go distal.
Yeah, I agree. But we see we are a little bit with the wire. You see it?
There you go.
Okay, here it's better.
Because I think we won't be obstructed just at the proximal part of this. Maybe I can do a shot when this balloon is up. There we go.
It's 14 atmosphere. So now the next step will be to evaluate the length of the stent. So maybe we can use the length of the balloon to help us to decide. So it's a 20 millimeter balloon. It's at least 20, I would say 28.
23 or 28. Yeah.
28. Maybe 23 could be short because the plaque is going up to the little septal branch.
If you start from the ostium of the diagonal, it's true that 28 would be
better. And in fact, there is no major problem to take a longer stent because there is no major branch after, so it's not an issue.
And the length of the size?
Well, I take
larger than 2.5.
Yeah, 275 probably. Yeah. 275 and 28 millimeter.
275, 28.
I guess what might be a good idea is after we take this balloon out is to do an LAO cranial shot to still persuade ourselves that we can land the stent distal to the diagonal.
Probably also we can re-inject a little bit the nitrates. So I think we have some nitrates remaining. sometimes you can have a modification of the size of the vessel after balloon angioplasty.
To optimize the placement with precision of the stent just distal to the ostium of the diagonal, you have some trick to, or just you looking at the angio in different views, or?
I think it's multiple views. You can see in this view we're about to show that I think it does appear that we have a landing zone proximally. You're going to see in 1 minute, I hope.
John.
Got a nice dissection.
Yeah.
We can see the landing zone here. Yeah.
Just see it, I think.
Yeah.
If we have the dot of the stent.
Just at the level.
There is a landing zone.
Yeah. In the era of the drug-eluting stents, we have an assumption that you have to cover from healthy to healthy to make a stent, and then according to Bishar, he said that you do some form of spot stenting, not covering the whole area. Do you think that we don't have an IVAS now? We don't know what's the plaque morphology in the proximal to the diagonal. So if you believe that the plaque extending before diagonal, you have to cover before diagonal. So the landing zone starting before diagonal and then go to in. But this is you are afraid to do plaque shifting of what you assume that there's no lesion in the diagonal. So what you are going to do before diagonal or after diagonal?
This is an important question, and this question is really we can have this question for all the cases. And when you look at the angiography, at that point, the plaque is starting, that is say around 1 centimeter proximal to the bifurcation, the diagonal bifurcation. So in fact, your question, do we need to place a stent from here to here or to cover the most critical lesion? And during years, after the presentation of, not Ravel, because Ravel was a simple lesion, but the Sirius trial, and then Taxus 2 and Taxus 4, we believe that the longer stent will be the best. And this is coming from this slide, remember, from the issue from the Sirius trial, when you look at the event, in particular repeat vascularization, according to the length of the lesion or the length of the stent, there was a dramatic difference between the bare metal stent and the DES. And the DES was, the difference was so large that we considered that there was no difference there's no difference between short and long stent with DES. And this is not true. This is not true because at the same time, 2 years later, when you could look at the literature, particularly concerning the DES implantation in long lesion more than 20 millimeter, in fact, and I tell you this because I report this during one of the TCT meeting 4 years ago, and the talk was DES in long lesion, and I look at all the literature, and the MACE rate at 1 year, the mismatch rate was 20% in very long lesion. That is, this was totally different of what we saw on this plaque of Sirius. And I think that even with the DES, the shortest is the best, even with DES. And there is less risk of stent thrombosis, less risk of stent restenosis if we place a short stent, when I say short, reasonable 15 to 18 millimeter stent, compared to the very long stent. And so, to place the stent for healthy part to healthy zone to healthy zone, I think we have, this is true in the discrete lesion. Of course, we have to cover from healthy zone to healthy zone with 18 millimeter stent, what we have done in the Ravel study. All the stent have the 18 millimeter length. But when we have diffuse disease, I think we have to choose the spot that we want to treat using a drug-eluting stent.
I
This is
think
a change a little bit.
This question, because
I don't know if Ibrahim, you agree or...
I totally agree, actually, but my question with this regard, I mean, I would be a bit unhappy to leave. I think when you look at the lesions, whether it is proximal to the stent, which will give it strategically a higher importance than a lesion distal. For example, the case that we have done before, you see the lesion, there was a distal lesion. So you know that strategically, that distal lesion does not have that much importance compared to, say, this case maybe, I don't know. You know, you have more proximal lesion. So I tend to, if it is a significant proximal lesion, I tend to cover it. You know, significant means does not need to be 90%, maybe 50% of proximal, I tend to cover it. My question in this particular case, and I would like to know what the audience would do, is in terms of, you know, and my experience has been that whenever I try to avoid the bifurcation, so we put a stent right after the branch that you want avoid to compromise. When you try to, you know, by millimeter, just position that, you always get in trouble. I mean, at least I have seen a lot of people getting in trouble. So, and what I would do is I would cover prior to the lesion and then take care of the stent. Because if we put a stent here just after the diagonal, and then suppose you have a plaque shift, then resolving that technique or that problem is a much more problematic, technically speaking.
With two more stents.
Yeah, two more stents.
That's true.
So what I would do in this particular case, I don't think I will have a major plaque shift into the diagonal because the lesion, you know, in the LAD starts a few millimeters down below. So I will position a stent prior to the diagonal to after the lesion and then deal with the diagonal, whatever happens.
Yeah.
And the other question comes now we know that this diagonal does not have a significant FFR. So the FFR was 0.85, which means that you need to leave it alone. Now, if you put a stent from the proximal to the diagonal to distal to the diagonal, and nothing happens to the ostimal diagonal, so there is no angiographic compromise, would you do anything or leave it alone? I think I would tend to leave it alone because you have had a good FFR and
yeah, I would do the same.
And you wouldn't do another FFR.
I would do the same. I would leave it
If you had a compromise, that's a different question.
different.
Then you have to go in.
Yeah, but I agree. Yeah, for taking the decision to place the stent on the main vessel, just distal the bifurcation or cross over the bifurcation, this is very, very, sometimes very difficult because we know that what you say, if there is a plaque shift, at the end to cover it, we need two additional stents, one in the main vessel plus one in the diagonal. That it should be 3 stents implanted. So we have to be sure when you decide to place a stent just distal to the diagonal that we have a landing zone with a normal, we leave at least 1 millimeter distal to the origin of the diagonal in order to avoid really the carina shift.
Actually, last year, John, in learning the technique in EuroPCR, I think it was last year or the year before, there was a Szabó's technique to position the stent just after the side branch, which happened to be the circumflex, I think, that was positioning in the LAD, and it tended to be a mess because you know, the ostial was compromised, so they ended up putting 3 more stents, I think. Exactly what you said.
Yeah. It's very, very interesting comment. But any other comment?
But if there is a plaque shift, you mean that we should ignore any plaque shift